today is Dr. Barry Greenberg to discuss hyperkalemia in patients with heart failure. Welcome, Dr. Greenberg.
I'm glad to be here and join you to discuss what is a very interesting and evolving topic.
So can you tell us how common is hyperkalemia in heart failure?
Well, it's quite common. We don't have an exact handle on this, but certainly in a heart failure clinic, such as the one that I run, I see a lot of patients with hyperkalemia. And in the hospital, we also see this condition quite commonly. It's been estimated that overall, when you look at hospitalizations, and this is not only heart failure, somewhere between 1 to 10% of patients who are admitted do have hyperkalemia. But to be honest with you, that number in the heart failure population, both for the inpatient and the outpatient setting, really isn't known exactly. The only thing you can really say about it is that it is common. Hopefully we'll have those numbers shortly and be able to nail this down a bit further.
So what are some of the risk factors?
Well, the overriding risk factor is underlying CKD. That is, by and large, the most potent risk factor for patients developing hyperkalemia. But there are other ones, and they tend to be fellow travelers with the chronic kidney disease. To give you an example, heart failure, very common. That's the population that I take care of. And many of my patients have chronic kidney disease to some extent, as well as their heart failure. Patients with diabetes, also this population is likely to have some degree of renal impairment, and diabetes and heart failure, of course, very commonly occur in the same patient. The other group of risk factors, though, are medications, and although a variety of medications can lead to hyperkalemia, the ones that really stand out and the ones that we see and probably are a driving factor for the high prevalence and incidence of hyperkalemia in the heart failure population are the renin-angiotensin-aldosterone system inhibitors. That is the ACE inhibitors, the ARBs, the mineralocorticoid receptor antagonists like spironolactone and eplerenone, and more recently, the combination of sacubitril/valsartan, the neprilysin inhibitor, angiotensin receptor blocker combination. We actually got some very important information from the recent Paradigm study, which looked at a comparison of the LCZ696, the combination of neprilysin inhibitor, angiotensin receptor blocker, with the ACE inhibitor enalapril. And over the course of that study, somewhere close to 17% of patients developed hyperkalemia during the course of the study. There was no significant difference between the two treatment arms of the study, but hyperkalemia overall was fairly common with that number that I quoted you just before. I think that gives us an idea of what we're likely to see in clinical practice. And remember, that was a selected population, and patients with more advanced kidney disease were not included in the study. And patients also were vetted, if you will, by having to go through a single blind run-in phase during which, if they developed significant side effects to either of the drugs, they were dropped from entry in the study, so that the value of about 17% is probably a conservative one.
So what are the clinical consequences of hyperkalemia? Why does it matter?
Well, in many cases, it's asymptomatic. Patients don't know they're hyperkalemic, although with some patients, weakness and a flaccid paralysis may occur. One can see characteristic ECG changes with these patients, a widening of the PR interval, sometimes loss of P wave, widening of the QRS. And the most dreaded complication, though, are ventricular arrhythmias, and this indeed can lead to development of symptomatic ventricular arrhythmias leading to sudden cardiac death. And that's the real concern here. Patients with heart failure are already prone to these arrhythmias, and superimposition of hyperkalemia on the setting of heart failure is really something you want to avoid.
So are there any concluding thoughts about hyperkalemia?
Yeah, it's a problem that we face quite often in the heart failure population. There are no good long-term solutions, or there haven't been until recently for this, and what we were faced with was having to cut back on evidence-based medicine that have been shown to favorably affect the clinical course in this population. That is, we've reduced or even discontinued medications like the mineralocorticoid receptor antagonists or ACE inhibitors in an effort to get the hyperkalemia under control. That, of course, deprived patients of the beneficial effects of these drugs. Both classes have been shown to lead to an improvement in outcomes, and what was happening was that either patients were being dosed below the target level or not getting these drugs at all. With the availability of agents now to deal with hyperkalemia over the long term, I think we're going to have much more flexibility in using these drugs in the future, and that's a very welcome addition to our armamentarium.
Thank you, Dr. Greenberg, for spending some time with us today.
You're welcome. It was a pleasure.